fetus, 0 to 3 for nulliparous, and effacement of less than 50%. And of course, a fetus without the signs of fetal distress. So basically, how does it work? So atosyban competes with oxytocin receptors in the myometrium. It binds with the oxytocin receptors, thereby decreasing the frequency of contractions and tone of the uterine musculature, and thereby suppressing the contractions and thereby stopping preterm birth and preterm labor, leading to reduced preterm birth. There's two solutions that we've got. We've got a bolus dosage that's injected immediately, and then we've got a concentration that is 2.5 mils that is given by infusion. The way that it's given, there's a total dose. You start the dose off with your bolus dosage that is given over 1 minute very slowly as an IV bolus. After that, you will take we'll take a bag of 100 ml saline solution. You will retract 10 ml of that. You will replace it with the 10 ml of the oxytocin or atosyban. You run that at 3 hours at 300 micrograms per minute, or otherwise you would just run it at 24 ml per hour for 3 hours. Then you will reduce the rate. You will run it at 100 micrograms per minute, or otherwise it will be 8 ml per hour for another 45 hours. First bag will last you around about 6.5 hours, including the 3 hours of the 24 ml per hour. You will replace it with a second bag, then a third bag, and then a fourth bag. So the total treatment that you would give of Tractacil will be 1 and 8. This works like an antibiotic, so you have to complete the full course to get the full benefit. You should not exceed 48-hour treatment, and you can use up to 3 retreatments of this product. If we look at the efficacy when compared to nifedipine over a few hours, you will see that atosyban and nifedipine is equally effective. But if we look at delivery after 48 hours, we will see that the atosyban is 86.6% underlivered of 68.6% underlivered after 48 hours, where we compare it to nifedipine, it will be 52%. If we look at some Cochrane studies, if we compare it to beta agonists, atosyban resulted in significantly less maternal side effects. And then if you compare it to nifedipine, it was the same thing compared to adverse events compared to nifedipine. So atosyban is equally effective as nifedipine, but it has the safety much better safety profile compared to that. If we look at ProPES, this is to induce labor or to augment labor. The active ingredient in there is dinoprostone, PGE2. It is indicated for initiation and continuation of cervical ripening patients at term. That will be 36 completed weeks of gestation. How does it work? So basically, it's a vaginal insert that you would insert high into the posterior fornix, where it causes a pro-inflammatory cascade, increases the activity of collagenations and elastin, and thereby decreasing a regulation of hydrophilic glycosamine synthesis, and that leads to cervical ripening. It contains 10 milligram dinoprostone that's dispersed at 0.3 milligrams per hour. So the total dosage period is 24-hour period. So that's one of the benefits of ProPES, that you can use it over a 24-hour period. It's embedded in a non-biodegradable hydrogel polymer. So basically it dissolves in layers and gives you the sustained release. So it gives you the control. You know exactly how much dinoprostone has gone into the patient, and it really mimics the natural labor at 1 centimeter per hour. ProPES is administered in a single application. It's inserted high into the posterior fornix. It's turned transversely to prevent it falling out. So basically you will insert it, the patient will be stay recumbent for about 30 minutes. It will start absorbing the vaginal fluid, it will stay in suture and then start releasing the active ingredient. What makes this a revolutionary product is that it's got a retrieval tape, so it can be removed very easily and quickly in one step, a single step, by just pulling on the tape. And it will be rapidly metabolized and it's cleared from a circulation with half-life time of around about 1 to 3 minutes. So should there be any hyperstimulation or anything like that, it's removed, hyperstimulation is cleared up, and you can replace it after the hyperstimulation has cleared up then. So the active ingredient does not stay within the body should a emergency C-section be needed. It has been cleared out of the system. If we look at one of my favorite products, it's called Pabel. It's a long-acting oxytocin. It's called carbetocin. And some of the, there were some alterations made to oxytocin molecule to make it a long-acting oxytocin. It's indicated prevention of postpartum hemorrhage due to uterine atomy following delivery of the infant by either cesarean section or epidural or spinal anesthesia and following vaginal delivery of the infant. Carbetocin binds to oxytocin receptors in the myometrium. It stimulates uterine smooth muscle contractility, thereby ensuring that the uterine contracts post-delivery. If we look at the dosage of it, it's a single 100 microgram dosage that comes in 1 ml. It's either administered IV as a bolus injection after cesarean section, or it can be administered IM or IV as a bolus injection over 1 minute after vaginal deliveries. If we're just looking at it compared to oxytocin, the onset of action of carbetocin is 1.2 minutes, where oxytocin is almost immediately. But looking at the duration of action, if it's given IV, it's got a 60-minute duration of action, and the half-life time is 33 minutes, where it's given IM, it's 120 minutes basically, and it's got a 55-minute half-life time compared to 3.5 minutes that you have with oxytocin. If we look at the efficacy of the product with 500 moles blood loss, if you look at this rankogram, you'll see that carbetocin is ranked amongst the top 3 effective uterotonic agencies, but it's the only one that's just a single agent. If you look at the other 2, it's compared to, that's also in the top 3. It's igometrin with oxytocin, or it's misoprostol with oxytocin. So the carbetocin is the only one as a single drug that is in the top 3 for effective preventing effective blood loss of 500 mils or more. If we look at 100,000 moles, it's also ranked in the top 3. Again, it's the only single product, and it's not a combination product. Specifically because this is the Better Ops meeting, if we look at the Better Ops guidelines, it says that for prophylactic uterotonic, carbetocin or syntocin should be given, but the carbetocin is preferred due to its long lifetime and also due to the fact that it's temperature stable, and it's also not light sensitive. So the recommendation says that after vaginal birth, carbetocin should be given as a single dosage, or after cesarean section, it also be given as a single dosage. So that's just basically a few of our products that we've got available in the maternal health section. I don't know if there's any questions that anybody has.
Christy, thank you very much. I think we all know your products well. I think they're well positioned for us. So, and also in terms of your support for Better Ops and obstetrics in general, thank you very much for your presentation and thanks for being involved. So
thank you very much.
Okay, keep well. Thanks, Christy. I'm going to hand over to Amy just to introduce our next speaker. And there are a number of very good talks still to come. I'm looking forward to them. Thank you very much, Amy.
Great, thanks very much. Great, so I'm introducing now Dr. Vanneval, who I have the pleasure of working with. She is a specialist obstetrician and gynecologist from Belgium who has been in South Africa since 2015. She completed her last year of specialist training at Calafong Hospital and subsequently stayed on at Calafong as well as the University of Pretoria SAMRC Maternal and Infant Healthcare Strategies Unit as a researcher. Since 2022, she's been working at Rahima Moosa Mother and Child Hospital as a specialist obstetrician and is a fellow in maternal and fetal medicine through the University of the Witwatersrand. So thanks very much. And now we're going to be speaking about induction. Thanks very much, Dr. Vanneval.
Thank you, Amy. It's an honor to be introduced by my boss, which you've left out of the introduction. I just want to confirm if you can see my slides and hear me.
We're all good, Valerie.
Perfect. Thank you so much. So thank you for the introduction, and thank you to SASOG for the invitation to speak at the Congress as well. I'll try to very much so stick between to my time limits, because I know there's rugby at 5, but I live with a soccer fan, and I know there's big soccer at 3 o'clock as well. So for the sake of time, I'll just get going. So we're talking about induction and safe practices. So I thought to just tackle a few questions about what is induction, who should we induce, what must we counsel on, can we predict when it's going to be successful or not, who should not be induced, when should it happen, where and how, what if there's a previous scar, what is failed induction, and what should we do if it fails. So firstly, what is induction? I think we all know that it's stimulation of uterine contractions prior to the spontaneous onset of labor in order to achieve a vaginal birth or achieve childbirth. Again, like many, many things in obstetrics, the rates differ where you are in the world, at what level of care, and at what type of institution you are. So generally in the US, about one in 3 women undergoes induction of labor. But if you look at WHO numbers, that is only about 1 in 10. Who should we induce? And I think with more knowledge, especially on poor obstetric history, more knowledge on medical conditions in pregnancy, that list just seems to be longer and getting longer and longer. So this is a non-exhaustive list, but it includes hypertensive disease, all chronic gestational preeclamptic, diabetes, both pre-existing and gestational, previous abruption and stillbirth, rupture of membranes, pre-labor rupture of membranes, both term and preterm, post-dates and post-term pregnancy, suspected infections, growth restriction, intrahepatic cholestasis, current IUFD, isoimmunization. And then one that I just wanted to elaborate a little bit more on, given the recent trial that has been published, is should we induce big babies? And we're not talking about the big baby born to a type 2 diabetic who's uncontrolled, but the general big baby. And for this, I'm referring to the trial that was published online actually only this year, but in Lancet last year, is the actual big baby trial, which was a multi-center, open-label, randomized controlled trial. So the question was, should big babies be induced? Because we all know, I think, what the risks is of laboring with a big baby. Big baby defined as large for gestational age for the sake of the trial, with an estimated fetal weight above the 90th centile for gestational age. We can have a whole discussion on what graphs we are using, customized, universal, which ones to use, but they used customized graphs in their trial from Gardosi's group. So we know that big babies are associated with longer first stage of labor, with an increased risk of assisted delivery, Caesar, postpartum hemorrhage, shoulder dystocia, and 3rd and 4th degree perineal tear. So they mainly wanted to look at the incidence of shoulder dystocia, the prevention of shoulder dystocia, with the others as secondary outcomes. So what we know when it comes to big babies is we know what the risk factors are, but we still don't predict very well who has a big baby. Ultrasound is our best tool, but from previous data and including this trial, we only correctly predict who actually has an LGA baby in 40%. That's less than half. Some of the babies that we seem to label antenatally as large for gestational age are even born as growth restricted or below the 10th centile for their gestational age. So that trial was done in the UK, was a randomized trial in over 100 hospitals, I think in about 106. And they randomized between an elective induction or an earlier induction between 38.0 and 38.4 for women with large for gestational age babies versus the standard of care. looking a bit in more detail, but again, a discussion for another day, where standard of care you would then suspect would be, we'll just do an expectant management. But for many of these women, standard of care was still an induction somewhere between 39 and 40 weeks. So just basically a couple of days later. So what they found, so they did 2 analyses, an intention to treat, where there was no significant reduction in shoulder dystocia, which they attribute in the fact that there's about 400 women who were induced earlier, so there was a lot of crossover in the trial. So when they looked at the actual protocol analysis, so really the women who were induced at 38 weeks versus the other ones, they found a significant reduction in shoulder dystocia in the group that was induced a bit earlier. They also found that there was a reduction in cesarean section, a reduction in primary PPH, and no difference in 3rd and 4th degree perineal tears, which they were worried were going to increase due to the fact that the women were being induced. So this trial was actually presented recently, and I want to give credit to that at the Fetal Medicine Foundation's sort of online seminars or webinars you can follow, and was presented by Professor Quimby, who's one of the PIs of the trial, who then said that, should we now induce these big babies? Well, it seems that if we induce them a bit earlier, it seems to lead to less seizures, less shoulder dystocias, and less PPH, but there was an increased rate of short-time neonatal admissions. The standard of care, which again then wasn't really expectant management, but just an induction a little bit later, had no increase in adverse neonatal outcomes and a shorter hospital stay. They had then also done a cost analysis and found that, well, you have this big baby, maybe we should just do a planned elective Caesar, which in the cost analysis, mind you, done in the UK, seemed to be cheaper. So, and I quote her from that webinar, which I found very interesting, when she herself, as the PI, was now asked, should you induce a large for gestational age baby earlier, meaning at 38 weeks? Her answer was, remember your Hippocratic oath, do no harm. It should be the woman's choice. And if you then think about cost, should you maybe not induce those women and put your funds and your money into training your labor ward staff? Or do you want to induce the women a bit earlier at 38 weeks and put your money in, or give your money to the neonatologist because you'll have more admissions? So I thought that was a really nice conclusion from her side, but we know it's a British trial where there might be more expected management, less inductions. Now, when we induce someone, what should the patient actually be counseled on? And again, a point of discussion is, should there be a written informed consent for someone who undergoes an induction of labor? I think in private, that's probably routine. With us in government, it is not, especially where I work and where I have worked before. We did not take written informed consent of the patient, or do not take it. So what do we need to tell the patient? So firstly, what's the indication, and why is earlier delivery better than waiting for spontaneous labor? The change in the woman's expectations when undergoing induction of labor. So there might be a need for more vaginal examinations. What is a choice of place of birth? Not just in Europe, but even in South Africa, women choose to labor at home with the midwife, choose to deliver at home. So that needs to be reiterated with the patient. The potential need for assisted delivery. Induced labor seems to be more painful. What are the risks? So because we are sort of forcing a process that hasn't happened by itself, there's a risk of hyperstimulation, especially if we do pharmacological induction of labor, might lead to more fetal distress with a need for a cesarean section, risk of uterine rupture, and then a risk of failing the induction. And then what do we do? What are the pain relief options? Is there alternative options to inducing? What's the process? Because many women are being induced, but they have no clue what's going to happen. Should we induce, or should we straightforward bail out and go for a cesarean section, and what to expect for the baby? Can we then predict successful and unsuccessful induction? So we know that the factors that influence negatively the chances of successful induction are unfavorable cervix, being nulliparous, having had no previous vaginal delivery, being post-term, obesity, and a large fetus. Then the counterpart to that is who is more likely to have a successful induction, and that should all be part of your counseling. Women who are younger, multiparity, BMI less than 30, tall stature, an estimated fetal weight less than 4 or less than 3.5 kgs, and having a favorable Bishop score. Now, coming to this favorable Bishop score, and already here I want to allude to Dr. Morin's talk about following of guidelines. And I love that even looking at South African guidelines only, the different ones we have, but then including the international ones as well, that the cutoff for favorable and unfavorable is different wherever you look. It's similar, but it's still not the same thing. And obviously, I think we all understand that the Bishop score is also a bit continuous, and having a Bishop score of 6 does not mean you're going to fail and 7 you'll be successful. Obviously, the higher your Bishop score out of 13, the more likely you are to deliver or to have a spontaneous normal vaginal delivery. If we look at FIGO, the cutoff is between favorable and unfavorable is 6. NICE guidelines says more than 8. The South African perinatal guidelines use 7. Better Ops says less than 8 is unfavorable, but then suggests adding points for preeclampsia and having had vaginal deliveries before, and subtracting points for being post-dates, being melliparous or having had no delivery, and having ruptured membranes without labor. So that is, I think, an important point to acknowledge. Not that the actual score makes such a big difference, but if we then look at guidelines, that number might be the thing that decides on how you are going to induce your patient. Are we still going for a mechanical route with prostaglandins, or should we rupture this patient's membranes and start oxytocin? What do we know about the Bishop score? That having a Bishop score of 9 or more has the same probability of vaginal delivery as a spontaneous onset of labor. And once your Bishop score is 8 or 9, it has a negative predictive value for cesarean section of 96%. A small thing about postterm pregnancy and why it could be an unfavorable factor for a successful induction. So if you look, and this is from the NICE guideline, that by 42 weeks, 99% of women should have gone into labor spontaneously. So, and this, I think we see a lot in public health facilities in our government hospitals, is that women reach 42 weeks and above, and we are still, inducing them. The question is, and should we still induce them? Because the fact that they, in that 1% group of women who has not gone into labor spontaneously, generally, when we induce them, they tend to fail that induction and still end up with a seizure. So should we induce them or not? We also know that beyond 41 weeks, the risk of cesarean section increases, the risk of NICU admission increases, and there's an increased risk of stillbirth and neonatal death. Contraindications, who should we not induce? And these are the absolute contraindications. Placenta previa, vasa previa, having a non-vertex presentation, even though in the South African perinatal care guidelines, it bravely says that we should not induce a breech at a lower level facility. I think many of us do not induce breaches wherever we are. An active genital herpes infection, having had a prior classical or high vertical cesarean section or uterine incision, prior myomectomy breaching the cavity, 2 or more lower uterine segment cesarean sections, even though if you read US or European guidelines, some people might still consider inducing someone who has had 2 cesarean sections, having had a previous uterine rupture, non-reassuring fetal testing, and cervical cancer. When should induction happen? I think that is a talk that could take up a whole day, looking at all the indications and the available evidence and the guidelines on when you should induce a woman. We could talk about hypertension alone and have an eternal ongoing discussion on when one should induce a woman with preeclampsia, which, mind you, yesterday we had after our maternal fetal medicine meeting at VETS, where South Africa says induce at 34 weeks and the rest of the world says 37. So we're not going to go into detail. When depends on the indication, the evidence, the guidelines, and again, your institutional protocols. On timing of induction, the other trial I wanted to allude to is the 2018, I think 2018 ARRIVE trial, if I remember correctly, where low-risk nulliparous women were randomized. This is an American trial. And women were randomized between elective induction, between 39 and 0 and 39 and 4 weeks gestational age, and expectant management. So waiting until at least 40 weeks and 5 days if no spontaneous labor has occurred to induce those women. I should reread the trial in detail to find out why the neonatal outcome was the primary outcome and not the cesarean section rate, but I think that's probably purely from an obstetric point of view, or maybe being a bit narrow-minded, that if we induce, we're increasing the Caesar rate. but their primary outcome was a composite neonatal outcome of neonatal death and severe neonatal morbidity. And the main secondary outcome, then followed by others, was cesarean section. So their primary outcome was not significant, although it needs to be said that if they look at the neonatal outcomes, that it looked like there was a 20% decrease if the women were induced at 39 weeks rather than waiting, but that confidence interval had just included one. So not significant, although that decrease, I think, was actually there. So it does seem to, I think we can interpret it in a way that if we induce the woman for basically a non-medical reason, not like this hypertension or anything, if we induce that woman at 39 weeks, that we are not increasing the risk for the baby. In terms of secondary outcome, they did see a significant decrease in cesarean section in the group that is induced at 39 weeks, which I initially found a bit counterintuitive, but then I think we also know that once we go later in the pregnancy, we have a higher risk of stillbirth, so probably also fetal distress and more emergency seizures. And obviously, I think this one for myself was a bit more understandable, is that if we induce a bit earlier, we decrease the incidence of hypertensive disease. Where should induction of labor happen? I think in summary, again, it depends on where you read, there's different opinions. There's insufficient evidence on safety of outpatient pharmacological induction of labor. So the general recommendation is to not use E1, so misoprostol, and E2, dinoprostol at home. Ideally, induction should happen inpatient in a facility with the necessary staff, so the necessary nursing care, equipment such as need for IV lines, pump if we want to get to oxytocin, CTG machines, and access to theatre service. If we consider outpatient induction, the one intervention that is recommended would be a Foley's catheter, because it is less likely to cause problems. WHO actually has recommendations on outpatient settings for induction of labor, and specifically says that where possible, induction of labor should be carried out in a facility, and not just in any birthing facility, but in a facility where there's access to cesarean section. Why should we be inducing women out of a facility? The main aim when I was reading was not to ultimately deliver at home, but to mainly reduce the inpatient time. Outpatient induction of labor did not seem to decrease the cesarean section rate. So it's not because you were induced at home that you were more likely to deliver vaginally. So like I said, we recommend only using mechanical methods because there's a low risk of hyperstimulation, low risk of adverse effects, the main one being pain and discomfort, which ultimately would probably be the goal of your induction in any case. And the prerequisites of an outpatient induction are having reliable transport back to the hospital, explaining of warning signs, only should be reserved for women at low risk of complications, and having a review and backup plan in place. That same WHO guideline that said please induce women in a hospital where you have access to theatre does mention that you could perhaps undertake an outpatient induction if basically everything has been covered, there's a backup plan and so forth. Then going back to the UK and the NICE guideline, where I think compared to the US or other areas in the world, there are more home births. They do mention that you could consider an outpatient induction of labor with vaginal dinoprostol preparations in women who wish to return home, have no coexisting medical conditions, and make sure that you have discussed everything with her. Personally, not something I recommend, but that's a personal opinion. And I'm very worried, and I think I'm biased by working in a high-level facility where we see lots of complications because that's what we are trained to deal with. But I am not a big fan of the idea of a home induction of labor. How should women be induced? There are different methods of induction. So we know our mechanical methods, including the membrane sweeping, the Foley's catheter, rupture of membranes and mechanical dilators, and then our pharmacological methods, prostaglandin E1 or misoprostol, E2 or dinoprostol, oxytocin, if generally recommended to follow the rupture of membranes if the cervix is favorable, and combination. One of the reasons I could shorten my talk a bit is because Sakani gave such a fantastic and elaborate talk on oxytocin this morning. So I've basically taken that out of my talk, not to double the information. So thank you, Sakani, for that. And I think everyone will We'll thank us both to making the sports games on time. So I'm not going to talk about oxytocin. We'll talk basically about the unfavorable cervix, the prostaglandins, and the mechanical methods for induction of labor to basically obtain cervical ripening. So what do our mechanical methods of induction of labor do? They physically can cause cervical dilatation, but they also stimulate the release of local endogenous prostaglandins to promote cervical dilatation and cervical ripening. The first one, membrane sweeping. I think in overloaded antenatal clinics like ours and probably in other government institutions as well, we probably don't do enough, but we should be doing more. It is considered to be safe with some caution for a low-lying placenta. It can cause some vaginal bleeding and discomfort, but has been shown to increase the rate of spontaneous labor and reducing the rate of induction. Looking at data, 36% of women, so about 1 in 3, goes into labor after membrane sweeping at term versus 17% without the membrane sweeping. So about a doubling of numbers. The Foley's catheter then, so just using our normal catheters, inserting those digitally or using a speculum, generally recommended especially for experienced healthcare providers to just try digitally first. So we induce the Foley's catheter where the bulb or the balloon goes just above the cervix and basically mimics the pressure of the fetal head on the cervix, and therefore can then stimulate the release of the endogenous prostaglandins. We fill that bulb with 20 to 80 mils of normal saline. I think the South African prenatal guidelines is 50 mils. I've always put 60 before. Be careful with volumes over 80 mils because there's a theoretically increased risk of port prolapse because you might be dislodging the presenting part. Then taping that bulb to the leg can stay in situ for 24 to 48 hours. Some people say 12 hours. You can consider, and that is included in the perinatal guideline, using an extra-amniotic saline infusion. It actually has an equivalent effect to misoprostol for cervical ripening, has similar rates of cesarean section, but obviously less tachysystole or less hyperstimulation. It's cheap. It can be used for a trial of labor after cesarean section, so the women who had a previous Caesar, but preferably not to be used with a low-lying placenta for the risk of bleeding and a potential marginal abruptio and rupture of membranes for the septic risk. Mechanical dilators I have personally heard of but never used. So there are laminaria, which is sterilized seaweed, and dilapan, which is a synthetic dilator. So they basically work, I think, when I was reading about this, has an osmotic effect, so it absorbs water from the environment and then distends and therefore then gradually opens the cervix. So I would think, if I would put it in my own words, probably a bit of a tampon for induction, if I say it correctly. I had to look it up and saw that dilapan, I'm not sure, is actually available in South Africa, but like I've mentioned, I've never seen it before. It has a similar efficacy rate as a Foley's, but is a lot more expensive, and probably one of the reasons why it is not used that often if we have actual Foley's available. Coming to our pharmacological methods, so our misoprostol, dinoprostol, and oxytocin. So like I mentioned, I won't be discussing oxytocin again. So misoprostol is cheap. Then we get into the argument, I think, of what dose should we give. I think what everyone sort of agrees on is using 25 micrograms every 2 hours if we give an oral dose for an induction at term. Then there is the suggested use of 50 micrograms, but this now really depends where you read it. I think there's a general consensus that the 25 micrograms is probably the safest, but then it is mentioned in some literature that you could consider, if you see a nulliparous woman with a very unfavorable cervix, that your first dose could perhaps be 50. Then it says in one of our South African guidelines that maybe you could give 50 micrograms 2 hourly if there's no effect after 3 doses in nulliparous women. So it is a bit controversial, and I personally never used 50 micrograms, and I've seen a lot of, not a lot, but quite a few adverse outcomes after the use of misoprostol in the 25 microgram dose. So I personally would be very cautious in using a 50 microgram dose especially as a first dose if we haven't seen a response to misoprostol yet. This is now the one consensus, I think, on misoprostol is absolutely contraindicated to induce labor in women with a scar after 28 weeks. I looked at the FIGO chart on the use of misoprostol, where it is mentioned that you could use 25 to 50 micrograms every 2 hours orally in induction. It also says that misoprostol is not contraindicated in grand mal tips and that you could perhaps also use your misoprostol in a scar before 24 weeks. What's with misoprostol? So why is it such a tricky drug? There's a risk of hyperstimulation and therefore also fetal distress. It's got side effects. And one of the biggest issues that also makes it different than the dinoprostol is that you can't take it out. Once it's there, once it's in and it's working, it's in. It needs actual tocolysis to reverse. It does not have a short half-life like oxytocin, where you can just close the drip and within a few minutes it should sort of start wearing off. You need tocolysis to reverse its action, and it might be more difficult to reverse or to tocolyze than dinoprostol. I think everyone agrees that there needs to be fetal monitoring before and after each dose. The duration thereof, there's no consensus. Many people suggest 20 minutes before and after, so a total case of about 40 minutes. Then, and this is even staying within our own borders of South African guidelines, can you use a second cycle after the first cycle has failed or not achieved labor yet? Let's not call it failed. Better Op says don't use a second cycle of miso. The South African prenatal guideline says yes, use a second cycle of miso. I don't know why there's a difference. Does it have to do with the fact that there's less induction agents available maybe in the government sector, more in private? I am not sure why the difference is there. But again, alluding to Dr. Moran's talk of let us all follow guidelines, it is tricky, I think, if we have South African guidelines that are a little bit different on some aspects of obstetric care. Then dinoprostone coming in many different available preparations. I think in the US currently there's only a Propes, but this has a different name. But the actual vaginal insert that contains 10 milligrams of dinoprostone available. We still have gel, I think Prandin gel available in South Africa. In Belgium, we used to use Prepidil gel, so also containing dinoprost. And then Prostem tablets, I think available in 3 milligram tablets and 0.5. I have not seen the 3 milligram ones here. I was used to using those back home in Belgium, but here I know of the 0.5 milligram tablet and then is used in a 1 milligram dose. So the general recommendations in South Africa to use dinoprostone would be the 1 milligram tablet intravaginally 6 hourly times 4, a Propes vaginal insert of 10 milligrams for about 12 to 24 hours, or Prandin gel in the posterior fornix 6 hourly times 4. So basically all 24-hour cycles of induction similar to the misoprostol. Should we be using a dual method? I think the answer to that, so mechanical and pharmacological, so our Foley's catheter with a drug, I think the answer to that is probably yes, especially if the cervix is unfavorable to use a Foley's with your prostaglandin, because it seems to lead to a shorter induction to delivery interval and maybe also to less cesarean sections. The WHO recommendation on induction of labor says use a Foley's with oxytocin if you have no prostaglandin available. What do we do if a woman has a previous cesarean section? Having worked both in Belgium and South Africa, I've realized that the practice is very, very different. We would happily induce everyone who had a scar, whereas in South Africa, I feel there's obviously more uterine rupture as well, less access to immediate cesarean section, but a lot less induction of women with a scar. I think if we want to counsel or even consider an induction of labor in a woman with a scar, we need to look at factors that are predictive of a successful VBAC, such as, and when we ask the students what are the risk factors or what are the factors predictive of, there's always the clever one said, having had a previous VBAC, yes, exactly. If you've had a previous VBAC, that's the most predictive factor that it might just work again. Having had a vaginal delivery before. And something that I sometimes feel is not really included in guidelines is, but look at the previous the indication for the previous Caesar. If the previous Caesar was done for twins or for breech and this baby is cephalic, maybe we should consider inducing the woman if there's a need for induction. If the previous Caesar was done for failed induction or for obstructed labor, my counseling for the patient would probably be a little bit different in terms of what is the potential success rate. Why are we also scared of inducing someone with a previous scar is the risk of uterine rupture. So the numbers that I found after one previous lower segment cesarean section, that if you have a spontaneous labor, onset of labor, TOLAC or trial of labor, your risk of rupture is about 0.15 to 0.4%. When we induce or augment that labor, we increase the risk of rupture by a factor of 2 to 3. So it is important to tell a patient that even though absolute risk of rupture was small, the fact that it goes up times 3 if we're trying to induce becomes significant, especially if you then look at, for instance, at Rahima, we have large numbers of laboring women doing over 1,000 deliveries a month. That would account for a large number of women who actually ruptures their uterus. So I think it comes down to counseling and shared decision-making and letting the patient have input as well. How should we induce those women if we've agreed on inducing them? So we would recommend using a Foley's catheter due to the low risk of hyperstimulation, perhaps amniotomy. Again, the controversy, what can be used with caution? Should we be using dinoprostol? So our prostaglandin E2, Better-Op says yes. South African perinatal care guidelines says do not use prostaglandins to induce a previous scar. Oxytocin under specialist care with appropriate monitoring, with a lot of caution. Even though it's not that oxytocin doesn't increase the risk of rupture, but it's easier to titrate and stop. So oxytocin can perhaps be used with caution. Contraindicated, misoprostol, and like I said, the South African guideline says all prostaglandins. Then coming to what is failed induction of labor. Another, I think, point that is up for discussion. Is it not achieving labor at all? Is it not achieving an active phase of labor? Or is it not achieving a vaginal delivery? I think that is difficult. I think many of us, if I ask Amy, me and her won't agree. For me, failing your induction is not just not getting into labor. What happens once you are in labor, we can maybe try and manage, but if we can't achieve labor, what should we do? So looking at some definitions, Better-Op says labor is not progressing to the active phase after one cycle of induction. FIGO says we can't reach the active phase, but then also says you must try at least 15 hours of oxytocin with ruptured membranes, which I think maybe is a little bit long. NICE says labor doesn't start after one cycle of induction. Another definition I saw was there's no progress after 18 to 24 hours of oxytocin after you've ruptured membranes in the active phase. But then I think you also need to reach the active phase before you can then call it failed. So it is a bit controversial on how do we label failed induction. What should we do if our induction seems to fail? Review the indication for delivery, because the general consensus everywhere is that failed induction does not mean cesarean section, but no one has a clear answer on what you shouldn't actually do. So review and discuss with the patient what is happening. Consider your indication for delivery and your clinical circumstances. Perhaps offer a rest period, especially after a first cycle. Look at different agents. Look maybe at rupturing membranes and oxytocin, maybe a second cycle of miso, but like I said, even the South African available guidelines do not agree. Maybe discuss cesarean section even after the first cycle with the patient, but always make sure both mom and baby are fine. So in summary, a bit of also my personal opinion is that I think induction of labor is a very useful intervention. I recommend doing it in facility with following guidelines and recommended dosages, knowing the limitations of having different guidelines available, ensuring mom and baby are fine, and having shared decision-making with the woman. My personal conclusion is that with appropriate counseling, the whole family will most likely be very happy, even if your induction failed just like mine. And that's it. Thank you.
Okay. Thanks for the pick of the cuteness. She's so sweet. Right. Thank you very much. That was a really fantastic talk. I'm just trying to see if I see there are some questions on the chat. One was, would you recommend application of traction when using the balloon catheter or not?
Yes, because you actually want to mimic the pressure of that fetal. One of the mechanisms of action is the fact that the bulb that's filled with water should be pressing on the cervix, mimicking a well-applied fetal head. The traction will probably help, I think, just intuitively speaking. I sometimes don't tape it to the leg because I think that also might be uncomfortable, and if the woman changes position, she loses traction. What I personally do, and I'm sure many people might laugh, is I ask the woman to put on it herself every 10 minutes or so, just to apply traction to what they can tolerate. I don't tie women to the bed with a 1 liter vaculator, so she can't move anymore. That I do not do.
No, absolutely agree. There's another. How long should we rest the patient between the second cycle with oral misoprostol, and how many cycles are allowed?
So I think most people will rest the patient for 24 hours, just to give it a bit of time. We can reassess, see maybe if labor would still start. So I think the general consensus is probably 24 hours. How many cycles are allowed? I don't think there's a limit. I would, however, say that the chance with every cycle of still achieving a labor and successful delivery will decrease. One of our image candidates is looking at how many women still deliver successfully with a second cycle of misoprostol, so not with another agent. We've done misoprostol 24 hours, let's do a second cycle. How many women still achieve normal delivery without needing a cesarean section, fetal distress, or something else?
Yeah. So there was another question here. It's a little bit different. Can a third VBAC be attempted if you've had 2 successful VBACs? I think the concern there is there's a point at which you're going to rupture if you keep going with the VBACs.
If I had to answer, I would have quoted my boss who said, you can only try this car so many times.
Right. Okay. So let's not quote me. Okay. So I don't think there's an exact answer on that. I do know that there is a concern about it, but I have never seen anything published on it precisely. This is another one which I think is often used as an excuse for a Caesar. Should an unengaged headed term be taken as a contraindication to induction of labor?
No. I think you need to be cautious. I think you need to be careful when you rupture membranes. You need to do that control. But I think every woman should get a chance to labor. I don't think it's a contraindication. There's no evidence of symmetry. I think you still do a clinical assessment, even though that's probably a skill that got lost. I think a good assessment and discussion with the patient beforehand, knowing that maybe it's an unfavorable factor, the head is still high, it reduces your Bishop score, but I don't think it's a contraindication.
Okay. And then one other ARRIVE trial was done on nulliparous women. Can we safely extrapolate the outcomes to multipara women?
Not really, because they're different. Although I think that we probably would have better outcomes if we induce them earlier, because they generally have more favorable Bishop scores. However, one of the criticisms of the ARRIVE trial is that these nulliparous women were generally already very young and healthy, which if you would look at multiparous women will not be the case. So I think you can argument both ways that the outcome would be different if you do the trial on multiparous women. But I don't think it is wrong looking at, how should I put it? If you look at the data from the trial, I don't think it is wrong to maybe then also offer an elective induction at 39 weeks to a multiparous woman.
Okay. And then one last, extra amniotic saline infusion, is it still practiced for induction? And can it be applied in our context in South Africa?
I've never done it before. It is part of the South African guidelines, so you can try it, but I've never done it before personally. Maybe it's something we should consider doing, but it is in the perinatal care guideline, and I think in Better Opt as well.
Okay, right. Maybe next week. Okay, great. Thank you very much, Dr. Van der Walt. Dr. Van Walt, you can carry on. Thank you.
Thank you very much, Valerie. That was a very, very good talk. So our next speaker will be Dr. Denise Sproul. Denise qualified at Stellenbosch initially. She actually just sent us a note now that the camera has taken a long weekend, so we're not going to see her, but we're going to hear her. She specialized at Stellenbosch, where she was a senior lecturer for 5 years. She's published and spoken quite widely. She has been the chairman of the South African Registrars Association and also been involved with that significantly throughout her training. She has now helped out at our fertility unit for the last year. And I've asked Denise to talk to us about the IVF pregnancy. Is the playing field equal? And are there specific things that we need to look out for? So Denise, we're looking forward to your talk. Thank you very much.
Hi, can you hear me?
Yes, we can.
Great. And can you see my slides?
We can see your slides as well, yeah.
Wonderful.
Just go to presenter mode if you don't mind, Denise. Next to the slide at the bottom, next to the thing that makes it bigger and smaller, bottom right. Looks like a little tripod.
Slideshow.
Slideshow.
I don't have mine is in a full screen. Is it there now?
No, it's still thing. Go. You see where the slider is at the bottom right hand corner. It goes 100%, 100 and whatever. Right next to that, there's the plus minus at the bottom. You'll none it down with your cursor. bottom right.
On my right, there's nothing.
Go down your cursor. Yeah, you should see it go down a little bit. Yeah, that little button there. Can you see that button?
It's off my screen. I think if I
Press escape. There we go. That button there. Yeah.
am I on it? Because I can't see it.
No, you nearly had it.
Do
you want me to run your slides for you, Denise?
If you don't mind. Let me stop sharing.
Stop sharing.
Apologies for that.
There we go. Is that what you're looking for?
Perfect. Yes. Can I control them, or are you gonna just move on?
I'm gonna have to do them for you.
No problem. Sorry about the glitch, but thank you everyone. And my talk is definitely going to make up time. It's very short and sweet, mostly because there is actually no guidelines or recommendations on how to approach a pregnancy after ART or IVF. So that is definitely a gap in the literature, and maybe something someone should look into at some stage. But just to remind everyone, what is ART? It essentially includes all interventions that include in vitro handling of both human oogocytes and sperm, or of embryos for the purpose of reproduction. So this includes your IVF, your intrauterine inseminations, and then all the extras that you can add on to IVF, like your ICSI, your INSEE, your PICSI, which is essentially just like higher level things for IVF, where we use magnifications or techniques to inject sperm and find the best sperm to inject into the egg. So just taking a few more things into our hand to optimize the process. So before we even get to fertility treatment, the patient has traveled quite a long road before they've sought any help or arrived at these clinics. And I just wanted to paint a picture for you. About 2 to 5% of all births in high-income countries are now from IVF or ART. And this number is going to rise in the future in these countries. These patients have spent months or years trying to conceive at home without any success, before even trying to go to their own GP or their first point of care to get any kind of intervention or testing or any of those treatments. They have to keep navigating societal expectations and emotional strain. It's repeated disappointments every time they get their menses, coping with that uncertainty of when they're going to fall pregnant, if they're going to fall pregnant, planning for the future, not planning holidays because you just don't know what your life is going to look like. Patients track cycles, they use apps, they try every kind of diet, cleanse, detox, you name it, to try and improve their fertility status. And it puts their relationship under strain, turns intimacy into work. And this can be especially difficult because you forget why you're trying to have a family in the first place. As I already mentioned, they might have undergone multiple investigations, treatments, and doctor's visits, which added up costs before they got there. It's truly a journey of hope and resilience. So once they're finally at a fertility clinic, they have to then undergo consultations, and we aim at trying to identify a cause, if there is a cause, to better individualize the treatment plan for that specific couple. So every plan and every couple's treatment plan is individualized according to their clinical situation, but also their financial means. And it's not a quick fix. By the time they arrive at these clinics, like I said, they've been busy for years or months, and they have this expectation of it's just going to be 1 month and then we're going to be pregnant. But that's not the truth. It's possibly months of cycles and treatments, finding the right medication, not overstimulating or understimulating before you actually get a successful pregnancy test. We have to navigate ethical decisions on, do we need to use donor sperm or donor eggs? And then there's that emotional preparation where people are hopeful, but you should also be guarded with expectations because fertility treatment can only do so much. Once we actually start the process, it's again ups and downs. So once we get to the egg retrieval stage, how many eggs do we have? How many are mature? How many can we use? Is the sperm result better? And then deciding what kind of fertilization methods. As I mentioned, is it just a straightforward IVF, or do we have to add in all these extra techniques like ICSI and IMSI to try and find that sperm, the best one we can find, and inject into the embryo? Into the egg. Once we've actually got fertilization, it's then another waiting game. How many are going to divide with a good division pattern? How many are going to make it to a blastocyst stage? And every day there might be a dropout rate, and that hope and resilience is tested. If patients are lucky to get blastocysts and embryos that are available for transfer, they need to make the decisions if it's going to be a fresh transfer, so essentially within that cycle, or a frozen transfer, or is it going to be a natural or a down-regulated or programmed transfer? We're going to explain that in the next slides. You must also decide if you're going to do genetic testing. So we can now do PGTA, which screens for aneuploidies, and this improves implantation, reduces miscarriage, but it does not eliminate the risk of chromosomal mosaicisms. Also decreases the time to pregnancy in older women, and it should be considered if the female partner is older than 40 years of age. You can do another kind of genetic testing called PGTM or SR, which is used for the monogenetic disorders or structural rearrangements. And although the data is not robust, there is no evidence between ART and chromosomal abnormalities of the newborn. There is, however, a higher prevalency of chromosomal abnormalities in these patients as a whole, but we find that the link is actually due to the advanced maternal age after we've adjusted for that risk in the risk analysis. Next slide. So the whole process of your fertility is about balancing the caution with celebration. It's important to recognize that once these patients have fallen pregnant and they present to the general obstetrician, that this is most likely a high-risk patient and it's going to result in a high-risk pregnancy. So some of these high-risk risks are advanced maternal age. They could have undergone previous uterine surgery with either septums being resected or having undergone a myomectomy. Many patients also have polycystic ovarian syndrome or other underlying conditions such as thyroid dysfunction or diabetes. There is the risk of multiple gestations as well with ART and IVF, but less so these days. And then the emotional and psychosocial anxiety and fear and risk that goes along with this whole process. They've definitely got a heightened anxiety and fear of loss. And these women and couples are at risk for depression and other mental disorders because of this journey that they've traveled. So early pregnancy, it's very important to note that things are a little different for the woman who's undergone ART. Most of the women need to have luteal support with progesterone to support the pregnancy, either vaginally or intramuscular injections, which can be every second day for up to 8 weeks. Some guidelines go up to 12. and even possibly estrogen support to support the endometrial lining. Serial beta HCGs are done to confirm the pregnancy and then to confirm it's a viable pregnancy. So you want to see that doubling after the 48 hours. An ultrasound confirmation is usually done at 5 weeks for the gestational sac, and then between 6 and 8 weeks for the crown rump length and that positive fetal heart. The early miscarriage rates seem to appear the same for ART versus spontaneous pregnancies. And however, there is a very slight risk of an ectopic pregnancy. And this is more to do if you're going to do a frozen or a fresh transfer. There seems to be a lower risk in the frozen transfer compared to the fresh, with a 0.35 odds ratio. The other important part to address in this early part of the pregnancy is the emotional and, like we said, psychosocial components. So it's important to give emotional support and validate that effort, but also the grief that they've gone through. There's been many losses before they've gotten to this positive outcome, and how resilient the couple is. We need to address the lingering anxiety of the what happens next feelings, and that heightened anxiety about possibly still having pregnancy loss or complications, even though you now have a positive outcome. There's also quite a lot of pressure to feel grateful despite this emotional distress and turmoil that you're constantly feeling, because you just don't want to give into that feeling that everything is okay after you've undergone such a hard road. So these pregnancies are precious, and we need to have full care and thoughtful deliveries. So a natural versus programmed frozen embryo transfer, just to give you a little bit of background, a natural cycle is essentially when we transfer back a frozen embryo on a woman's natural cycle. So we time it from her last menses, we track a dominant follicle. Once we see that it's large enough where it would be ovulated or released, we control that state. And then we want to know that she's that dominant follicle that's been released is now going to form a corpus luteum. That would have been when that particular egg would have been fertilized and implanted. So we will implant back as if that egg that had been released from that dominant follicle has now formed a pregnancy. So that corpus luteum will support the pregnancy, and it's in the most sort of natural way. The programmed or down-regulated frozen embryo transfer is when we block all of the stimulation essentially from the brain, and we block that whole HBO access and take control of the cycle and time it ourselves. So we provide all the support for the endometrial lining and then the support for the progesterone with either injections or vaginal progesterone. There's pros and cons to both. And one of the biggest reasons why we use the programmed one is either women are not ovulating themselves, they are anovulatory, or they're from far and they've had to travel, and there is only this window of time to do the transfer. But natural definitely does seem to have better outcomes in pregnancy. So the slide has been up for a while, so I'm sure you've seen all the stats attached to the risks. I'm not going to read the stats out, but essentially there's definitely a higher risk of hypertensive disorders in pregnancy, and that includes the risk of preeclampsia. The articles don't distinguish between early and late, they just say preeclampsia, so definitely be nice to delve into that a little bit more. But there's also a high risk of induction of labor, higher risk of postpartum hemorrhage, higher risk of cesarean section, macrosomia, and then the increased risk for placenta accreta or the morbidly adherent placenta spectrums. I think that was very clearly linked to if you've had previous surgery or uterine surgery to optimize your fertility in the first place. So the takeaway message from this slide is that the programmed or down-regulated frozen embryo transfer will result or could result in a higher risk pregnancy and should be treated as such. So just other general complications from ART, we've already said that the preeclampsia and the gestational hypertensive disorders increase as much as 2.9-fold. These complications are not related to natural or down-regulated cycles. These are just in a whole, so fresh or frozen, down-regulated or natural. So this is more the overall risk. There's also an increased risk of your gestational diabetes, moderate to severe anemia and thyroid disease, multiple gestations. But as I said, this has now come down and on a decrease since before, because all the societies for reproductive health has moved away from multiple embryo transfers and moved to single embryo transfers. And that's definitely brought down the rate. So it's very varied amongst the world and from institution to institution. There's also an increased risk for low birth weight infants. And this is particularly if it's a lower risk, if it's a frozen embryo transfer compared to a fresh embryo transfer. So antenatal care, as I said, there's no recommendations or guidelines out there. So this is maybe just what I think we should consider based on what I all read to prepare for the talk. I think every pregnancy should have its own, have an increased surveillance. If someone is saying that this is how they conceived, and they should have individualized care based on their risk factors and identifying the high-risk patient for that high-risk pregnancy. Also, the fetus, as we've seen in the slides before, they are also having an increased risk in the pregnancy. So we definitely need to identify these risks and then try and optimize the antenatal care. We want to have early ultrasound in the first trimester to confirm it's intrauterine and to confirm that there's no miscarriage and that the pregnancy is viable. And we need to have a fetal assessments to confirm that there's no chromosomal abnormalities or structural abnormalities, and specific emphasis should be on the placental assessment and if there's any risk for the morbidly adherent placentas. Fetal growth and Doppler assessment should be done throughout the pregnancy to screen for that macrosomic baby or that low birth weight baby. And then possibly we should include the oral glucose tolerance test as a screening tool at 26 weeks to screen for GDM. I can think in particular the woman with a background from polycystic ovarian syndrome or advanced maternal age, they should be high on the list to be screened. And then individualized delivery plans to suit should be in discussion with the patient, not only for their clinical risk, but also for the emotional and psychosocial part or treatment plan for the pregnancy. It's very important to, as we said, there's very heightened anxiety, there's an increased risk for depression and an increased risk of PTSD symptoms in these patients. So you might need a multidisciplinary approach with a psychologist or psychosocial support to aim for the best care for these patients during their pregnancy. Next slide. I've already touched on this a little throughout the pregnancy, but throughout the presentation. But these patients carry a fear of loss, and it's not over after the first trimester. It carries on all the way right through the end. This can be particularly high in patients who've had prior failures or miscarriages. And they also carry quite a lot of guilt about sharing pregnancy news. They might have met some people during their fertility journey at the fertility clinic, and if they have a successful outcome compared to other people, there's quite a lot of guilt feelings there. We've already mentioned the elevated risk of antenatal and postpartum depression, even after a successful conception. And it's difficult for the patient to transition from that infertile sort of person to the pregnant identity that they now have. So supporting these patients with sensitive communication and validating and celebrating each milestone is very important. Next slide. We've also touched on this already, but the delivery complications are also increased. So like we said, the morbidly adherent placentas or the placenta accreta spectrum is higher in these patients, especially after prior surgeries or your frozen embryo transfer cycles. And then your postpartum hemorrhage risk is also increased, mostly linked to the accreta spectrum or that uterine atony, multiple gestations. And operative delivery is also higher in these patients. And you can see it's quite a bit higher, the 66.7 compared to 33.3% for spontaneous pregnancies. These are just the references I used, and then I just want to say thank you for having me. And I think that this is definitely a space where we should put there's a definite gap in the literature, and we can benefit maybe from SASOG making some guidelines or recommendations. Thank you.
Denise, thank you very much. I think it's quite thoughtful. I think there are a couple of take-home messages. I'm going to attend to the questions quickly and maybe first question is, there's a high rate of cervical cerclage insertion in IVF pregnancy. Is this common practice, or are they placed on indication or as precautionary measure?
Johannes, maybe you could help me here, because I haven't read I didn't see that in any of the readings that I had. I would hope that that is due to increased screening with ultrasound, seeing a short cervix, but I didn't see that as a risk.
As a general rule, there's no increased incidence in that. I think the only place where that might be relevant, obviously, if your cervix shortened, I don't think there's any difference in the background. However, if you should have had a cervical cancer, you had a trachelectomy, then obviously you must monitor it. But I think the gynae oncologists are quite good in inserting those cerclages. We've had to convert two of them to intra-abdominal cerclages if the cervical cerclage doesn't stick. But I think in general rule, there's no increased reason to put them in outside of the ordinary. Okay, Denise, the second question is, what is the dosage of progesterone for luteal support and which type is most effective? Micronized progesterone vs dihydrogesterone. Do you want to comment on that?
It depends on the cycle and what if it's a downregulated or natural cycle. With the natural cycle, we use the vaginal progesterone a lot more, and that seems to be enough because the corpus luteum is also supporting the pregnancy. And with the programmed or downregulated cycle, we need to use the intramuscular and the vaginal for that extra support. And Dr. van Waard, you would know a bit better than me here when it comes to all the protocols internationally, but we use every second day. So it is very high doses of progesterone in the intramuscular doses for the downregulated cycle, but they even recommend every day to support the pregnancy.
Yeah, I would agree with Denise. I think there's no real indication to use progesterone support outside of IVF cycles. So we use it depending on the type of cycle. The natural cycle transfers, we just use vaginal progesterone. And normally we'd use it up to 8 weeks of pregnancy. And the downregulated cycles where there actually no hormonal support from the patient, corpora lutea itself, we definitely go higher. And the evidence says there are certain limits or certain ceilings to some routes. So very often we combine different routes, either intramuscular with vaginal or subcut with vaginal. But that also depends on some of the measurements that we do. I would not change the support from where the patient comes from. So if the patients come from a fertility unit to you on a certain regimen of progesterone support, I would stick to that regimen until 8 weeks of pregnancy when the placenta takes over. All right, then the next question, Denise, what would be the cause of the higher risks in programmed FETs?
With the programmed FETs, the estrogen progesterone, we are really trying to stimulate that and take over the cycles. So we do see that that's, or there is probably a link from what I understand, because we're using so much additional support, that's most likely the increased risk. I think also with the programmed FETs, like we said, it's not, we're trying to almost trick your body into doing what it needs to do to support the pregnancy. So I'm sure there's some sort of immunological response as well that would then increase your risk for preeclampsia. I mean, that whole inflammatory response and cascade is what we think is one of the causes for development of preeclampsia. So I think it's probably related to that. Dr. van Waart, you're on mute.
Sorry, yes. No, I agree with you. I think we don't clearly know why it happens. We just know it happens. We just got to be cautious and know that we must make sure that we do those blood pressures later on in pregnancy. The next question is, how can you explain the high rate of monochorionic twins in IVF? And is a general rule to do cyclage after IVF? Maybe I can answer that. I'm not aware of any higher risk of monochorionic twins in IVF. I think it's similar to background. There might be one or two articles that say that, but certainly I don't think as a general rule there's a higher rate. And then we don't generally put in cyclages after IVF. I think you monitor them as you should. And if there's an indication, definitely you do that. And then the next question, Denise, I recently had a patient who was 58 years at 22 weeks pregnant from IVF with OSA donation. Is it ethically acceptable? Maybe I can answer that because I think we were involved in writing those guidelines. We would definitely in our unit not do pregnancy in patients after 50 not for the maternal reason only, but I think there's a very strong ethical consideration that children need to have parents. And if you make somebody pregnant when they are 60 years old, when that kid is 15 years old, then their parents will be 75. And I think it's a big question. I think the American guidelines would consider it after 50, maybe go to 55 in individual circumstances. But definitely, we won't do this in our unit. And then the last question, Denise, should these patients be on aspirin because of high risk of preeclampsia? You just want to touch on that?
It's a difficult question to answer because there is no guideline. I think maybe, but I don't know. Yeah, the risks of, even if you have a patient with preeclampsia or you suspect has risks of preeclampsia, that guideline for starting aspirin is also quite complex, and that's divided into your major risks and your minor risks, and you need two of the minor risks to then start aspirin and prevent. But I don't know. There isn't a guideline. I think that this is something that we should look into, and it's something that we should do like a robust evidence research to see, does the risk of the programmed frozen embryo transfers, is that the same sort of risk profile as someone having a high BMI or having previous preeclampsia? What does that look like? Because if that's true, then we should. But at the moment, that's not answered. I don't know if Dr. van Waart would like to also give his
We don't routinely put patients on aspirin in IVF cycles. They all get a NIPT scan at 13 weeks. And if you try notching, then definitely they'll go on aspirin, but that's very similar to what we do with all high-risk patients. We see it as a high-risk pregnancy. So not as a routine. Denise, thank you very much. Thanks for your trouble. I think it is a very enlightening talk as IVF is increasing and the patients go out to their obstetricians. I think we as obstetricians also remember the main person in your life, if you have a patient with IVF, will be the doctor that delivers that safely, and they will hold you in high regard for the rest of their lives. So look after them carefully. And Denise, thank you very much for your talk.
Thank you so much.